Okay. Hi again, folks. This is video number 2 on the topic of brain imaging, and this is from chapter 3 of Johnson and Jacobson. So early knowledge of brain organization was largely based on observations of patients with brain lesions. These were typically studied post-mortem. So you look at the focal brain lesions in the tissue and then correlate these with various damaged brain areas. So this was done in the case of Broca's area and Wernicke's area. These were localized as expressive and then receptive language centers, respectively. So as you're aware, Broca's area is in the left hemisphere, inferior frontal lobe area, and then Wernicke's area is left hemisphere, superior temporal lobe area. Damage to each of these regions resulted in linguistic deficits. The disadvantage, of course, at this time was that you have to wait for the patient to die in order to correlate behavioral, neurologic, and neuroanatomical findings. So development of imaging technology. In the earlier 20th century, X-ray was developed. So this provided 2D imaging of bony anatomy, abnormal calcifications, and eventually there was development of radiodense contrast agents. So this allowed for imaging of vascular anatomy via cerebral angiography and study of ventricular anatomy via pneumoencephalography. The latter technique is no longer used due to the extreme pain that it causes. Since the mid-1970s, though, many other imaging techniques have been developed. So computerized tomography or CT scans, magnetic resonance imaging or MRI, functional magnetic resonance imaging or fMRI, positron emission tomography or PET scans, single photon emission computed tomography or SPECT scans, and near infrared spectroscopic mapping, NIRS mapping. Cerebral angiography uses X-rays with a contrast agent to examine vascular anatomy. So you're looking at the arterial and venous structure. These are used to diagnose blockages, aneurysms, which are weakened or bulging vessel walls, stenosis or vessel narrowing, hemorrhage or ruptured vessels, vascular inflammation. So you might see swelling or irregularities. In this particular in cerebral angiography, a thin catheter is threaded into the femoral artery, typically in the groin, guided to the area of interest with the aid of X-ray fluoroscopy, and then a contrast agent is injected through the catheter into the blood vessels, making them visible. A risk associated with this particular technique is that you might damage blood vessels, dislodge an embolus or a blood clot. The contrast can cause allergic reactions and actually worsen kidney issues if the patient has renal problems. So there are definitely risks associated with it. This is often used in conjunction with CT or MRI to reduce risk. In this case, contrast is injected and vessels are visualized without the use of a catheter. And this is referred to in the case of the CT as a CTA. So CT or computed tomography yields 3D representations constructed from X-ray images. So the patient is placed in a tube that rotates as it takes a series of X-rays. These images are then compiled into cross-sectional slices of the targeted structure, useful for visualizing structures at different depths within the body. So tissue attenuates or weakens the X-ray beam as it passes through the body, and the attenuation rate varies with the density of the tissue. In CT scans, high-density tissue such as bone appear to be white, and low-density tissue such as water appears to be dark. A contrast agent may be used to differentiate tissues of similar densities. A CT scan has a high spatial resolution, so it's ideal for detecting structural abnormalities such as ventricular abnormalities, bone fractures, blood, edema, etc. And it can produce clear non-invasive angiograms with contrast agent, so CTAs, and it's often used to manage hypertension and trauma. A benefit of this particular type of scan, the CT, is that it's fast. It can be accomplished in less than 5 minutes. It's inexpensive, and it's often a first choice for imaging of acute trauma, especially in the case of stroke. Disadvantages of CT: there's moderate to high radiation exposure associated with it. A typical chest CT might expose one to about 175 times more radiation than a typical chest X-ray. Etiologic studies have indicated that repeated CT scans can increase the risk of cancer, particularly in children. The contrast agent can exacerbate renal issues or allergies, as previously stated, and the CT can be susceptible to artifacts in regions surrounded by thick bone, such as the brain stem or the temporal lobe. And early stage ischemic strokes don't appear very clearly on CT. They might just look like very subtle changes. So there are some risks associated and some disadvantages for sure with CT scans. However, if the patient really needs a CT scan, the benefits far outweigh the risks. Here is an example, a clinical example from one of my facilities that I work at. I work, as I mentioned before, I work in skilled nursing facilities and throughout Northwest Ohio. And this particular patient was an 84-year-old female with a history of AFib, atrial fibrillation, so heart problems, breast cancer, hypertension, type 2, diabetes mellitus, and vitamin B12 deficiency, who returns to this facility after being hospitalized for a left femoral neck fracture. The patient was previously at this facility following a motor vehicle accident and a fall at home. According to her medical record, the patient's son indicated that he received a call from the Northward Police on 4-9 stating that his mother had run a stop sign. She hit a tree, and then that her car was stuck in a shallow swamp. The patient's son reports that there was no airbag deployment during the motor vehicle crash, and the patient refused transport to the emergency department for treatment. On 4/12, the patient's neighbor called her son and reported that the patient was confused and lethargic and was in the same clothes as the previous day, which was out of character for her. A few hours later, the patient fell in the street while walking the wrong direction to the neighbor's house and presented to the emergency department per EMS for concerns of left hip pain. Patient report indicated that the fall was caused by slipping in a puddle. The patient denied hitting her head in the motor vehicle crash, and she denied the fall. During rehab stay, she was found to have a left hip fracture and was sent back to the hospital for further eval. The patient was diagnosed with a closed subcapital fracture of the left hip. Chest X-ray indicated possible pleural thickening and mild cardiomegaly. CT of head indicated subacute infarct, postmedial right temporal and occipital lobe within the posterior carotid artery distribution, and subacute infarct of the right thalamus. So these are the CT results from this particular individual. This person had a relatively low BIMS and SLUMS scores. SLUMS is a common cognitive exam that we use in our particular SNFs. And she presented with severe cognitive linguistic deficits. She had decreased orientation, short-term memory loss, thought organization issues, visuospatial reasoning issues. She actually had hallucinations and a few other interesting symptoms. And she also had moderate verbal problem solving and safety awareness deficits. So we recommended skilled speech therapy 5 times a week for 4 weeks, at which point she would be reevaluated to determine her appropriateness for therapy in order to address these cognitive communication deficits. Okay. Magnetic resonance imaging, or MRI. Hydrogen atoms are present in every part of the body. The hydrogen atom core contains a single proton with an inherent spin. A magnetic field will make these protons spin around the longitudinal axis of the magnetic field. And the stronger the magnet, the faster the spin. So about 50 million times a second in a water molecule. So the patient is placed in a tube-like machine housing a strong magnet that is used to align the majority of the water protons along the same longitudinal axis. When excited by radio wave pulse at a particular resonant frequency, these internal protons begin to spin in phase with each other in the transverse plane. After this pulse, protons relax back to their normal spin about the longitudinal plane and dephase in the transverse plane. So after the pulse during this relaxation phase, the MRI signal is measured, and protons in different tissues have different relaxation properties. That is, slower versus faster relaxation times. So the result is that there is an image that is produced, and the lightness or darkness of the image corresponds with various properties within the tissue. So radio pulses are used for MRI, and these are very loud. And the patients are given earplugs in order to kind of protect their hearing. The pattern of electromagnetic excitation, the timing of reception, and signal processing aspects vary with particular MRI techniques. There are many of them. Here's just a few: the T1 weighted, T2 weighted, fluid attenuated inversion recovery or FLAIR, and diffusion weighted. So T1 weighted MRI is basically, it says how much time it takes the protons to relax back to the spin around the longitudinal axis. So water-filled tissue appears as being dark, fat-filled tissue is white, and gray matter is darker than white matter. One example is in the case of multiple sclerosis, fat is stripped away and is replaced by water. T2 weighted MRI indicates the amount of time to dephase the spins in the transverse plane. So water and fluid-filled tissues appear to be bright, fat appears to be less bright, and gray matter is brighter than white matter. So this is pretty sensitive to tissue pathology, so abnormalities are typically viewed as being white spots. Fluid attenuated inversion recovery, or FLAIR. This is used to suppress signals from fluids, so it suppresses CSF to highlight lesions like in multiple sclerosis. This is similar to T2 weighted, but water appears to be dark. Okay, diffusion weighted MRI. This is used to measure the diffusion of water molecules in tissues and study the connectivity of axons and white matter. There are a few different applications: diffusion weighted imaging, apparent diffusion coefficient, and diffusion tensor imaging. And these all have their own particular idiosyncrasies and uses. DWI is able to detect ischemic strokes of 5 to 10 minutes after the onset of symptoms, versus CT, which is not able to detect acute infarcts for 4 to 6 hours. So this is also faster than other types of MRI. This is very useful in terms of being able to identify ischemic strokes. MRI is not standardized, meaning different centers have adopted different protocols, and different physicians might adopt personalized protocols. So interpretation of MRI must be done carefully. MRIs can also produce an angiogram, as can CTs, and these are called MRAs. An advantage of MRI is that there's no radiation risk, so it's safe for pregnant women and individuals vulnerable to radiation, unlike CT. There is a higher resolution imaging of soft tissue versus CT. There's better contrast resolution, that is discrimination between similar but not identical tissues versus CT. And it's more sensitive to brain parenchymal pathology and is less affected by bone artifact than CT. The disadvantages of MRI are that they are much more expensive. They take quite a bit of time, 15 to 60 minutes versus 5 minutes for a CT. So it is very loud. It's done in a small space, which is very difficult for individuals with claustrophobia without anesthesia. And it can be affected by movement. So the patient must stay still during the duration of the scan, which is inappropriate for patients with movement disorders or patients that are unable to cooperate without anesthesia. As with other technologies, the contrasting agent, if you're doing a CT or an MRA, the contrast agent can have a negative impact on kidney function. It's contraindicated in patients with metal implants. So things like old pacemakers and old cerebral aneurysm clips. The newer pacemakers and clips are typically okay. CT is also better at imaging bone. Functional MRI, fMRI. So fMRI is an application of MRI that produces images of metabolic function. So it uses blood oxygen level dependent or bold contrast to indirectly map neural activity in the brain and spinal cord. So oxygen-rich blood, known as oxyhemoglobin, and oxygen-poor blood, known as deoxyhemoglobin, have different magnetic properties. Deoxyhemoglobin's T2 weighted signal is slightly decreased compared to that of oxyhemoglobin. So given that fact, there's a differential imaging of oxyhemoglobin versus deoxyhemoglobin. So this can produce an image. With functional MRI, the subject alternates between a control or an active state and an experimental or active state task. For example, watching static crosshairs versus a flashing checkerboard. Tens to hundreds of images are acquired in both states and are compared to determine cerebral locations where activation levels are different between the two states. Thus, fMRI is used to localize regions associated with different brain functions. So you can look at language or speech or sensorimotor functions, visual functions, memory, emotion, learning. The patterns of activation are typically superimposed on structural MRI images. And the images are typically averages of findings from multiple study participants. The advantages of fMRI is that it evaluates brain function safely, non-invasively, effectively. There's no radiation, it's low risk versus like a PET scan, and it's easy to use, it has good resolution. The disadvantages are that the patient must lie completely still because it's susceptible to motion artifact. If sedating meds are used, this might suppress brain activation that one wants to observe and thus makes the technique kind of pointless. And there's interpretation issues with patients with abnormal brain activity at baseline. For example, subclinical seizures. And there's issues of interpretation generally. Are multiple areas of activation, like the changes in the blood flow patterns caused by a particular task or due to changes in oxygenation in draining veins far away from the source of the activity? Brain activation for even simple cognitive tasks is distributed across neural networks. So localization studies assume activation of a particular region is correlated with performance of a particular task, but spatial precision is somewhat deceptive. Challenges to fMRI linear transformation model have also been posed. Like, is the strength of the fMRI signal really proportional to local neuronal activity averaged over time? These are questions that still need to be answered. Positron emission tomography, or PET scans. This produces 3D images of metabolic processes, blood flow or receptor density within the body. So a small dose of radioactive tracer is injected intravenously, which is absorbed by tissues and organs. And as the tracer decays, it emits a positron that combines with a nearby electron and yields simultaneous emission of 2 gamma rays in opposite directions that are then picked up. The patient is placed in a ring-shaped PET scanner with a camera that detects the pairs of gamma rays that were emitted by the tracer and locates their origin with high spatial precision. And the computer converts the emission into a 3D image. And this is a PET scan can be performed simultaneously with a CT scan in the same machine. So that's one positive aspect of it. Since glucose is used by the brain for energy, the concentration of tracer uptake indicates tissue metabolic activity. So how much tracer is taken up by the tissue is an indicator of the amount of metabolic activity of that tissue. So this is often used for the evaluation of cancers or epilepsy, early stage Alzheimer's disease. And it can actually, one particular application of it, can measure neurotransmitter density, which is quite interesting. Advantages of PET scans: they can detect neurotransmitter receptor density. Disadvantages: exposure to radiation. The tracer could be unsuitable for pregnant and nursing women. There's a high cost, it takes a lot of time, and the images are often blurry because the positron travels a short distance before meeting an electron. Okay, single photon emission commuted tomography, or SPECT. It's similar to PET scans. It uses a radioactive tracer, but not positron emission ligands. So SPECT isotope emits single photons versus PET, which emits two photons in opposite directions. So an intravenous isotope is taken up by the brain at different rates in proportion with local blood flow. So basically it detects reduced blood flow. There's 100% uptake in less than a minute, which is quite impressive. And there's a rotating gamma camera that detects the radioactive isotope location. SPECTs are useful for seizure diagnosis. So looking at blood flow to the seizure focus, there's greater uptake in epileptic brain regions. It's useful for dementia, stroke, and traumatic brain injury diagnosis. And there's a particular application called DaTscan, which is useful for early detection of Parkinson's disease. Advantages of SPECT: it's relatively time efficient in that it takes less than an hour. It's widely available, it's cost effective. Unfortunately, it generates relatively blurry images and with low spatial resolution. Nurse imaging. Near infrared light beams in the 700 to 2000 millimeter range can travel through the skin, through bone and other tissues to be absorbed by hemoglobin. Beams are absorbed differently by oxygenated and deoxygenated blood. So NIRS can map changes in cerebral oxygenation during various tasks. Thus, it's relatively similar to functional MRI. Cerebral activation typically indicates increased blood flow. So activated regions have greater oxygenation. So advantages are that it's more portable and less expensive than MRI. Disadvantages: it can only detect oxygenation rates in superficial cortical tissue, so not deeper or throughout the brain like fMRI. Electroencephalography, or EEG. This measures voltage fluctuations resulting from ionic current flow from neurons of the cerebral cortex, and it's measured via electrodes placed on the surface, so on the scalp. And it produces a series of tracings that reflect voltage changes over time at different locations on the scalp. It shows abnormalities in brain electrical activities, and it's often used for diagnosis of epilepsy, differentiation of different types of epilepsy, location of areas of epileptic seizure, and it's sometimes also used for evaluation of coma, encephalopathy, neurodegenerative diseases, and sleep disorders as well. So advantages of EEG: it's readily available, there's a low cost, it has a pretty good tolerance of patient movement to a certain extent, no risks to the patient, and high time or temporal resolution. The disadvantages is there are primarily is that there's poor spatial resolution. So it represents an average electrical activity of a particular region of the cortex measured at the scalp. So you're not able to get really fine, precise detail regarding the activation of the superficial regions of the brain. It's kind of an average of a certain region. You get poor recording from deep brain regions, so it's superficial only. It takes time to set up the electrodes, and there are actually muscle activity and eye movement artifacts that are associated with it as well. So one has to be careful in interpreting artifacts. There is a particular application of EEG referred to as evoked potentials. EEG waves resulting from presentation of a particular stimulus. And these can be combined with MRI, and it facilitates localization of presumed sources of evoked potentials in the brain. And it might be used to identify brain lesions, which would cause a delay in one or more components of the potentials. Magnetoencephalography, MEG, or MEG. This measures magnetic fields produced by naturally occurring electrical currents in the brain, and it's performed within a magnetically shielded room to isolate the scanner from environmental magnetic fields, and it can be used with MRI to localize sources of brain activity. It's useful when combined with EEG for locating seizure foci. Advantages of MEG: along with EEG, it has a high temporal resolution, and it measures brain function directly versus fMRI, which measures hemodynamic response. And there's less distortion from intervening tissues in EEG. Disadvantages: like EEG, there's poor recording from deep brain regions. Now, there's something called the WADA test, a very interesting test, also referred to as an intracarotid emobarbital procedure. So this is used to demonstrate cerebral dominance prior to brain surgery. So baseline language and memory testing is performed prior to the procedure. So things like object naming, verbal comprehension, repetition, automatic speech, etc. Then a catheter is placed in the femoral artery that's directed to the internal carotid artery. An angiogram is performed to look at the venous structure or the arterial structure. Then anesthetic is injected into one carotid artery at a time, resulting in temporary anesthesia of brain regions supplied by that artery. The patient is asked to perform motor tasks. So hold up the arms, wiggle the fingers, and count aloud as the anesthetic is injected. Within a few seconds, the contralateral arm should drop and fingers should stop wiggling, indicating paralysis of one entire brain hemisphere. Testing for language and memory is then performed again. When the dominant hemisphere with respect to language is anesthetized, global aphasia should ensue for a few minutes. When the non-dominant hemisphere with respect to language is anesthetized, speech may be dysarthric, but language should be relatively unaffected. So this is not permanent. There's a recovery, and during recovery from the anesthesia, paraphasic errors, perseverations, naming errors will often occur. And then language and memory function is retested after the anesthesia wears off. So this is done primarily to determine which hemisphere is dominant for language for this particular individual. And 99% of individuals that are right-handed, it's the left hemisphere, and in about 75% or so of left-handed individuals, it's also the left hemisphere. So advantages of the WADA test: it demonstrates which hemisphere is dominant for language function for a patient. Disadvantages: there are risks involved. So dislodging plaque, arterial spasms, arterial wall injury, and these can all result in strokes. So therefore, it's not appropriate for non-essential use or to study language dominance in normal volunteers. It's too risky. And this only tests lateralization dominance. It doesn't look at anything more precise. Okay, and the last one we're going to look at today, electrical stimulation mapping. So this is used for localizing language and other functions in a patient prior to ablation surgery, like removal of a particular brain structure. And this might be done in the case of tumor removal or in the case of an individual with epilepsy that has drug-resistant epilepsy, which requires removal of certain parts of the brain to prevent the seizures from occurring. And this is done in order to spare the language centers from excitation, from excision. You want to make sure that whatever you're removing is not involved in language. So this can be done outside or inside the operating room. So in the OR during surgery or outside the OR prior to surgery. So small electrical pulses are introduced that interfere with cortical activity in one area of the brain for a brief period of time. And responses to stimulation, like motor, sensory, or none, determine the function of that particular cortical region. Stimulation of the primary motor cortex produces positive responses that can be felt by the patient or seen by the examiner. Stimulation of an association area does not produce a detectable response unless the patient is engaged in a task that utilizes that particular cortical area. For example, cessation of breathing or paraphasic errors might indicate an area involved in language given pulse stimulation. EEG is often recorded during stimulation to detect seizure discharges to ensure that the pulse that disrupted language, that it's the pulse that disrupted language and not a seizure. Large variability in language localization does exist across normal individuals. Many individuals have additional language areas besides Broca's and Wernicke's areas. For example, the temporoparietal area is an area involved in language, or one area may be absent in a person. Also, the basal temporal language area might be involved in speech perception. And in disordered individuals, early onset epilepsy patients might have a language dominant shift to a non-dominant hemisphere or to adjacent cortical areas in the original dominant hemisphere, which is quite interesting. Okay. All right, and that does it for the imaging section. Thank you for watching, and I will be back with another video shortly.